But please welcome everyone to this session. We're going to talk about liver tumors, both benign and malignant. And in doing so, I want this to be helpful to you. So please don't hesitate to stop me and ask questions. Or if you don't want to stop me, you can type the question in the chat box and we will take some time for questions at the end. I'm going to go slowly so that we have time for questions, but also there's so much to cover on this that I think we will want to spend another session also on liver tumors. The goal is really to make sure that we have a framework. Kind of like when you build a house, you build a foundation and then the pillars to attach the walls to. And then we'll have some case examples to practice using that framework to differentiate different tumors. Mostly, we will talk about the common tumors with enough variety of different cases and examples, so that when you encounter an uncommon tumor, something that doesn't fit what you have seen before, you will know not to just call it, another one of these tumors. So you'll know that it's an unusual variant. And that's a big part of pathology, is getting enough experience to know when something is close enough to be the same thing or when it really is quite different and needs a different evaluation. Okay, so in terms of the WHO classification, I imagine that most of you use this classification in your work. We have a number of benign tumors, the adenomas, hepatocellular adenomas, bile duct adenomas, and so forth. There are rare adenofibromas that we can encounter. And then in the biliary tract, we also rarely see some of the tumors that are more common in the pancreas, like the intraductal papillary mucinous neoplasm, IPMN. That is a low-grade benign mucinous neoplasm that can become malignant. And the mucinous cystic neoplasm that has the ovarian type of stroma. I was very excited when this week we had a case of mucinous cystic neoplasm of the biliary tract, but I haven't been able to scan that slide to be able to show to you yet. So you'll have to wait for a few more weeks and we will put that on for next month when we talk about that. On the malignant side of things, we have hepatocellular carcinomas with several variants. The more significant variant is fibrolamellar hepatocellular carcinoma, because that has both a different genetics and a different clinical presentation, age group, and so forth. And then just several other morphologic and other variants of hepatocellular carcinoma. Hepatoblastoma is usually a pediatric tumor, and I'm not going to spend a lot of time on that. My colleague, Dr. Yu, has done a very nice video presentation on hepatoblastoma, which I will make available to you as well. And then the more common cancer like cholangiocarcinoma or combined hepatocellular and cholangiocarcinoma, and then the neuroendocrine tumors and mixed neuroendocrine, non-neuroendocrine tumors. So these are also just as we would find in other organ systems as well. So we'll start with some of the benign tumors. The hepatocellular adenoma. This is usually presenting in a patient without cirrhosis. It is identified when you find the sort of what looks like a portal triad, but there's no bile duct. So when you see arteries without a bile duct, you should start to thinking about the hepatic adenoma. And with this lesion of the last decade or so, we've recognized several subtypes. And these have both prognostic and diagnostic implications. And so making the distinction is sometimes important for these. About 5 or 6 years ago, we had a session in Hue, and Dr. Yunsil Yu from Korea presented a very nice presentation on these subtypes of adenomas and their differentiation. I think I've shared the slides from the publication, from that publication on the website. So let's just go to a needle biopsy, as is often the case. We have several cores, and we try to get a good section so that we can evaluate and see what we're going to have here. As we go from low power to high power, we'll start with looking at the portal triads. So here's one here. And, as we look here, we see there's a vessel. Not quite sure if we've got a corresponding bile duct. So there's some inflammatory cells here. These may be a little bile duct right there. So that's probably not part of the lesion. As we move further inward, we just see sheets of hepatocytes. We're not seeing much in the way of portal tracts. Here's a central vein-like structure, another central vein-like structure. And then here we have what looks like it should be a portal tract with a little arteriole, a vein here, but no bile duct. And so sometimes that's the only clue you have that this is an adenoma. Now, with some of these adenomas, the margins are not really distinct. And so you can't draw a line necessarily and say, here's where the adenoma stops and the benign liver begins. And so this is a challenging diagnosis. And it helps to know that there was a mass seen on the imaging, and that the needle tract goes into that mass reliably before you can make that diagnosis. So typically in that sort of a situation, I will, say, like in this, I have few portal tracts, I have some unpaired vessels without bile ducts. This is consistent with a hepatic adenoma. So I think you can see as we go here, we have very little in the way of portal tissue. And then even when we get here, where we have a little bit more, we see a little arteriole, some veins, nerves. But this is the only biliary material we see. If we're in this size of a portal tract, we should see a pretty large bile duct, which we're really not seeing here. So this also would sort of reinforce that impression. But with the presence of a little bit of biliary tissue, you can't be quite as certain. So we'll go on to the next slide and just take a look at that as well. This is obviously a macro resection. And again, as you look at it, you don't see really, you see a little bit of lobulation here to this liver tissue, but it's not a real sharp margin between what is probably the lesion and the surrounding tissue, the surrounding benign liver. So we'll look at this big portal tract here, and we see a large vessel. Looking down here again, we see these small draining veins, but we really don't see definite biliary structures. So there's a little nesting here to a couple of these things, but I think these are hepatocytes rather than bile ducts. And of course, if you have a question, you can do, CK7 stain, and that will highlight your bile ducts. But in this case, you don't have any of those in this triad area. Now, I suspect in most of your circumstances that you don't have the immuno or molecular profiling capabilities to subtype these adenomas. And so perhaps aside from maybe beta-catenin staining, which you might have for other purposes, the other markers that are used for subtyping are a little bit beyond the sophistication, I imagine, in most of your institutions. So I'm not even going to spend time on that for you tonight. You can read about that and so forth if you decide to take on that capability. It does have some implications for risk of progression to cancer and so forth. But I think with the criterion that we've given you, you have the wherewithal to start. Now, in hepatic adenomas, you can sometimes get areas of fatty change, sometimes just in the adenoma. That will be a hallmark feature, and sometimes not. It's not a consistent feature as to whether or not there's a fatty change in the adenoma, but sometimes we've seen that. Here's another example. Obviously, this one is a very vascular one. A lot of hemorrhage and so forth in this. And again, you would see that, when we got to the, found the portal type tracts, like here. Well, here we can see we're outside of that because here we have vessels and bile ducts. So this is obviously outside of the margins of the adenoma. And then this other tissue is more central. If we look here, you'll see vessels, hepatocytes, vessels, no bile ducts. So that's a very useful criterion to use. And of course, with this lesion, we expect there to be really no high-level anaplasia or dysplasia of the hepatocytes. They look very bland and benign. Because obviously hepatocellular carcinoma can also present with an absence of biliary duct architecture. All right, one more case. This one a little bit more geographical areas. And if you come back to these slides, I'll send you the link to these digital slides so that you can study them on your own as well. But as you come back, you'll discover that these are very difficult, as I said, to draw that line between where the adenoma is and ends and where the normal liver tissue comes in. Now, you've noticed that we have several resections of these lesions. Why are they resected? Well, they're resected if they have a risk of malignancy or a risk of complications, bleeding, or other sorts of issues like that. And so that's the primary reason for resection. Here is one of the special stains that we use. I believe here this is beta-catenin. So that's one of the subtypes. As you can see, this staining is negative. And so that excludes the one of the types there that we would be concerned about. Another stain that we would do here is, this is glypican 3. And that's a useful marker in both demonstration of the differentiation between a dysplastic or neoplastic nodule and benign liver. So in this case, we can see that this adenoma is entirely negative. We would not be worried about a dysplastic adenoma or a hepatocellular carcinoma. And I'm going to go further and skip over this part. This is another one of those stains that is used. This is sort of the geographical pattern that is seen in, as we'll see here, in with glutamine synthetase. And that again is one of the discriminating markers for subtyping the adenomas. Okay, we'll skip over that. And we'll go to bile duct adenoma. These lesions are usually small, usually less than 5 millimeters, not encapsulated, and they tend to be rounded. They have very simple tubular ducts and not cystically dilated. There's no atypia and no mitoses, but you can get some other, inflammation, granulomata, and so forth. And the reason to know about these is that they get biopsied. They get resected in cases that patients are being evaluated for resectable cancers. And so I think actually my first case here to show you is just such a resection. So here is a fragment of liver. This is a frozen section done in our laboratory. And we learned a lot from this case because the pathologist who looked at it first made the wrong call. This is a patient who was known to have pancreatic adenocarcinoma. And so we honed in on this rounded nodule here. And the interpreting pathologist thought, gee, there's a little bit of atypia here. There's small glands. I think this is metastatic cancer. And so as a consequence, the procedure was aborted and the patient closed back up. And then the next day, the rest of us looked at it and said, this looks like a hepatic adenoma. It's a difficult call. It's a difficult finding because you get, you don't get a good shot at this with optimal histology on frozen section. Now, what are the helpful features? Well, the rounded architecture could be seen in either a metastasis or a bile duct adenoma. The inflammation could be seen with either. And there's a degree of disorder here. It's not totally normal looking ducts. But as we look at these cells, the nuclei are fairly widely spaced. They're relatively uniform. There's not any of the what we would call the 4-to-1 ratio of nuclear changes. And that criterion is actually very useful in pancreatic carcinoma, that the range between the largest nucleus and the smallest nucleus can be greater than 4-to-1 in terms of size. So maybe this is our largest nucleus here, but I don't think it makes it beyond 3.5 or 4-to-1. It's not really comfortably beyond that. And some of them may be actually dual nuclei. So that criterion can be very useful on frozen section because the uniform frozen section artifact is applied to all the nuclei. So that's the little warning with bile duct adenoma. We'll look at another example here. I think this is actually a similar one. You see just a few millimeters. Here you can see there's, this is nicely fixed. You can see the nuclear details. And although there's a bit of wanderingness to these nests and tubules, again, you see how uniform the nuclei are. Did someone have a question? Okay, someone's just turned their mic on, that's all. So, okay. So bile duct adenoma, small rounded lesions, variable vessels, fairly uniform nuclei, maybe some inflammation, even granulomas and so forth with these lesions. Usually an incidental finding and benign. Biliary adenofibromas are very uncommon. They have the kind of features you think of with adenofibromas elsewhere. Some bile debris and so forth, a spindle-shaped stroma, relatively little pleomorphism, and a little bit of a sort of fronding architecture. Let's see if I've got one here. Don't think I do. Nope, I don't have one. Mentioned the intraductal papillary mucinous neoplasms, similar to those that we see in the pancreas. These do not have ovarian type stroma. These are more challenging because the epithelium can show degrees of dysplasia and even invasive carcinoma. And a variety of epithelial types can be seen, both sort of pancreatico-biliary as well as intestinal or oncocytic. Rarely gastric, but supposedly that's been reported as well. So here's an example of what one of these might look like. Let's see, where are we? Well, that's very cauterized there. I don't know if we've got a good histology here or not. Okay, so this was not a mucinous papillary cystic neoplasm. This is just the biliary adenofibroma with a cystic change and a little bit of spindle-shaped stroma. Not much in the way of epithelial lining, a few remnants of that here. So biliary cystadenofibroma. I think you can see here is a very benign epithelium and this slightly altered stroma. Now with this scarring, you might wonder about an intraductal about a mucinous cystic neoplasm, but I don't think this quite makes it to the ovarian type of stroma. Let's see. Okay, here's an intraductal papillary mucinous neoplasm that could be in the biliary tract and so forth. You see this very complex mucinous epithelium. And here there's a degree of, it's more cellular, you see more nuclear material here. So this is a lesion that has a degree of dysplasia. As you can see, you've lost some of the mucin. Here's a few cells over here that still have cytoplasmic mucin, whereas many of these cells here, they're mitotically active and you've got variable or little amounts of mucin left. There's still a little bit of basilar orientation to the nuclei, but this is a significant dysplasia in this lesion. Now, if we were to look further, we might find other areas where there's not the same degree of dysplasia, and that might be right here, where we see a little bit more mucin, but you still have some nuclear variability to these cells. Here's more typical goblet cells, so not as high-grade dysplasia in this location. So because these are quite variable, you have to both go on the architecture as well as the location of presentation. In general, these are in situ lesions, but because of the risk of malignancy, if you make the diagnosis on a biopsy or on cytology, and the size and symptoms are of note, with any degree of atypia, they will operate if it's an operable case. That's true both in the pancreas as well as in the biliary tract. Mucinous cystic neoplasm is also called hepatobiliary cystadenoma. I like the mucinous cystic neoplasm because it reminds me that this is similar to what I see in the pancreas. This is usually a multiloculated tumor with ovarian type of stroma. And again, because this is a potentially pre-malignant lesion, it can have dysplasia, and so it needs to be very generously sectioned to evaluate for that. The stroma is positive for hormone markers in most cases, and on occasion can actually produce, be a hormone producer. So you can actually get luteinized cells within this ovarian stroma, which can look a little bit odd, sort of like a little bit of a follicle generation because of that change. And that's the one I'll have to show you next time when we get together to talk about some more of these lesions. So focal nodular hyperplasia is the other major benign lesion that we encounter in the liver, both on imaging as well as occasionally on biopsy. This is actually a non-neoplastic liver. Again, the patients are not cirrhotic. And it's usually a fairly isolated single lesion that is well demarcated. So compared to adenoma, this is one where you can see the border of this lesion. It tends to occur more frequently at a young age and in young women. Again, we don't see portal tracts in this lesion in general, except at the very periphery. So like adenoma, we may not have portal architecture. And it generally has a sort of a central scar with thick-walled blood vessels and maybe some fibrous banding and other changes like steatosis and so forth that can also occur in this lesion. So here we can see a lobulated nodular lesion. With this lesion, because it's not as likely to be have that malignant potential, the desire to fully resect it is not as strong. But I think you can see here there is this nice demarcated lobularity to it. And we'll look at this portal tract here. And again, we see that there's no biliary component to it. So not everything that lacks bile ducts is an adenoma. As we mentioned, sometimes you can get fatty changes in these nodular hyperplasias. And there may be a little bit of atypia associated with it, usually not serious. In contrast to the adenomas, these are of a single type. They don't, the clinical pathological presentation is a little bit more recognizable under imaging. They can often identify these fibrous bands and the unifocal nature of these lesions. So a good ultrasound person or a good CT scan person will be able to recognize and suggest that that's what this is. See if I have another example here. Again, you see this nodularity. So it's kind of like this localized area of cirrhotic change, but the surrounding liver would be free of cirrhosis. This is sectioned at a different thickness, so it's a little bit more cellular appearing and not as prominent fibrous bands. But as we look at this, we don't see, portal tracts. We don't see evidence of those changes. Now, in some circumstances, if you have an aggressive radiologist who's very good with interventional angiography, you may see material like this. Does anybody know what this material is? It's purple blobs. This is polyvinyl alcohol. It's a thrombotic agent that is frequently used as an embolization mechanism to try to shrink these down a little bit, to temporize the blood supply. And obviously that is done to help make the surgery easier, this little smaller lesion and so forth, with variable results. But it often presents and leaves us with this sort of nested open spaces and occasionally these blue blobs of the embolization agent. Interestingly, we don't usually see thrombosis associated with this use. So I'm not sure how thrombotic it is, but it is still in fairly wide use. Okay, so we'll take a few more minutes and talk about the first of the hepatocellular carcinoma variants that we'll talk about, and then we'll save the rest for our meeting next time. But in the literature, there's these four primary variants of patterns that you might see with hepatocellular carcinoma. So one pattern is this trabecular or nesting channels and so forth, islands of cells. So you've got some intervening stroma and you've got what seems to be a degree of architecture. That's a fairly common pattern. The next pattern that I see with some frequency is this pseudoglandular pattern. So you see the cells form little circular structures with a central lumen-like area. So they look like little glands with a peripheral rim. And they generally tend to be fairly small like this and quite uniform one to the next. With the more poorly differentiated tumors, the higher grade tumors, you tend to have a solid pattern with a degree of anaplasia, with a degree of high variability between cells. And that can sometimes be associated with giant cells. So those four patterns are seen with some frequency. As I've indicated, I think the higher grade tumors usually are the solid types, whereas the lower grade tumors, well-differentiated tumors, usually have one of these two patterns, the trabecular or pseudoglandular pattern. And they may very closely mimic some of the well-differentiated or very well-differentiated tumors may be difficult to distinguish from benign liver tissue at times. Now, the WHO uses 3 grades of tumor, and then many other authors have used 4 grades of tumor, from well to poorly differentiated and so forth, grade 1, 2, 3, and 4. I think in reality, we're quite good with 2 grade systems, and reasonably good with 3 good, where a lot of things are in the middle. 4 grade systems are a little bit more challenging unless there's a very well-defined distinctions, and I'm not confident that that these are really well and easily applied. But I think we can tell the difference between the low-grade, well-differentiated tumors and the very high grade, poorly differentiated tumors, and leave the ones in the middle in that grade 2 category. So this is how the grade 4 tumors are supposed to be differentiated. Grade 1 tumor cells look a lot like normal liver cells. Grade 2 tumor cells, they look like mature hepatocytes, but they're larger and a little bit more hyperchromatic. They have sharp cell borders, and they'll form acini. Well, that's still a very well differentiated tumor. So those are fairly close to my mind. Grade 3, larger, more hyperchromatic, less cytoplasm, distortion, and giant cells. And grade 4 are just the very furthest extreme. You'll have to do the grading practice on your own because this tutorial was not really designed for that. That's more of an advanced skill in surgical pathology, and I'm not even sure I have enough practice in that. Now, in contrast, you may see more liver cancers than I do and have more practice doing that. So if you want to share some slides and images of how you make those grading decisions, I'm happy to learn. Okay, so we'll talk for a few minutes about this particular hepatocellular carcinoma variant, the Fibrolamellar variant. And this is important for these two reasons. One, these are usually younger patients. There's usually no background liver disease, and almost certainly they have this fusion gene. And we usually do it by testing for this marker, PRK-ACA, and that test then confirms the lesion. You may end up having to do it just on the basis of histology, which is quite reliable, but not quite as precise, if you will, as the fusion testing. In general, these tumors don't fit well into that grading scheme that we just talked about because they have these very large cells, so they tend to look poorly differentiated, but they also will have fairly dense collagen bundles that often separates the cords or nests of the tumor cells. Okay, here's a biopsy, and we'll see if we can identify those features in this biopsy. Well, even at low magnification, we can see there's some bands of collagenized tissue. We see the color of this lesion, of the cells here. They're quite pink, and that suggests that these may be sort of oncocytic cells. There's a few little acini here. And there's a degree of anaplasia here. They're not organized with usual sinusoids. There's some nuclear atypia here, a ring cell. But it's this very pink cytoplasm, a degree of cytologic atypia that should suggest the diagnosis. Now, in this case, we don't have any normal liver tissue, so we can't say that the surrounding tissue is free of cirrhosis. But if we knew how old the patient was, that may help in steering us towards the fibrolamellar variant. We don't get a lot of fibrous tissue in this particular biopsy. Sometimes you do get a lot of dense collagen in the tumor, and there may be just a very limited amount of epithelium. It may have quite a bit of collagen. I think we're going to get anything in that piece. Let's see if there's something more down. We'll take a look at this piece down here. So it doesn't look like we have any more collagen in this particular piece either. But I think you can see that the architecture is different and the cytology is certainly different from normal benign liver tissue. Let's see another example. Again, a core biopsy. These cells are not as red as those, but they're certainly very pink, and there's a lot of cytoplasm. I think you would agree these kind of look oncocytic in this pattern. And here we do see these little strands of collagenized fibrous tissue in between and around some of these cell groups. Nice collagenized tissue there. Looking up a little further up here. Well, this may be here. Nice contrast. This is our benign liver tissue, right? We don't have those oncocytic changes. Here's our portal tract, and here we have a few little bile ductules going along. So it's not a background cirrhosis, as you can see from this fairly normal appearing liver tissue here, with nice liver cell plates, sinusoids, a few Kupffer cells here along some of these sinusoids as well. So that's a nice contrast between the tumor and benign hepatocytes. And we'll look at this other section here for more tumor. And you can see, again, very eosinophilic cells, some degree of anaplasia, variability, and this very collagenized matrix in between these nests and cords of cells. So fusion gene, younger patients, no background liver disease. Those are the things to remember about fibrolamellar hepatocellular carcinoma. There is some immunohistochemistry that can be very useful. Here, I'll just double check here. This is HepPAR1, an antibody you probably have. And as you can see, these cells in this liver tumor light up very brightly with HepPAR1. There. Some of the benign liver doesn't stain particularly well. Biliary ducts, that doesn't make sense. No, I think this is CK7. I'm pretty sure this is CK7 because it's staining the bile ducts here, as you can see. It's not staining the normal liver and the CK7. So that makes better sense to me. This tumor does usually light up with CK7 and has some other relatively unique features. Yeah, so this is the opposite. So these slides were mislabeled. Here's the HepPAR1. As you can see, here's the normal liver biopsying or showing its features, normal hepatic plates. And the tumor is brightly positive. So these oncocytic cells contain lots of HepPAR. It's very granular. That's what's making it have this oncocytic appearance that you find there. So those two stains are very useful, and probably most of your laboratories may have those laboratories or those stains available. Let's see, one more stain here. Let's just see what our control here is lighting up. Well, let's see, this is CD68. Okay, so CD68 can also be a useful stain. I don't know if most of your labs have that or not. But again, you see some positivity in these oncocytic tumor cells with CD68. Okay, so I know there's a couple of questions here. So very good question, Dr. Lin. How to distinguish fibrolamellar HCC and scurus HCC? So actually, these two stains would be very useful. The hyper prominence of Hepar1 would be much stronger in fibrolamellar, and CK7 would not be positive in scurus HCC. And second question, how to distinguish steatohepatic HCC and HNF1A mutated subtype of hepatocellular adenoma on biopsy? I don't know the answer to that right off the top of my head, Dr. Lin, and so I'll research that question and come back to you with that question. Let's see. All right, so let's see how much more we have on, if anything, on fibrolamellar. Here's a resection example, just to give you an overall architectural appearance. Now here there is a little bit of nodularity to this normal liver out here. It sort of looks vaguely nodular, but we really don't see any cirrhosis or portal triad changes. So it's just sort of a pseudo nodularity from the staining, I believe, or maybe differentiating zone 1, 2, and 3. Here are our fibrolamellar tumor, very eosinophilic cells, the sclerosis here in between, as we've indicated. So a nice overall example of this lesion with fairly sharp margins and been resected here. This was the partial hepatectomy, leaving here a little margin. This was the closest margin. Okay. Another example, again, normal liver here off to the side, our tumor here. A little bit different staining character, not as much sclerosis to the tumor, variability, but we still do have this very pink fibrous banding in some areas. So the amount of this tissue can be quite variable. Okay, well, I think that's the last of my, oh, no, I've got one more here. This is to contrast with hepatocellular carcinomas, and one of the other changes that begins to come into play is the dysplastic nodule. So as we look at this, I think you can see even at this very low magnification that there's a high degree of nodularity here. There's fibrous banding around these nodules, and there are variable sizes. And then we have this nodule over here that looks a little bit different. So this begins to introduce the concept of, cirrhosis and dysplastic nodules and carcinoma. And that's becoming a more challenging issue, particularly as the number of people who may require transplants or treatment for hepatocellular carcinoma goes up. It can be challenging to distinguish the kind of atypia that we have in a nodule like this, which is clearly kind of a regenerative nodule in this background of cirrhosis, from the changes that we are beginning to see over here, where, this looks a lot like fibrolamellar carcinoma, does it not? We have fairly large eosinophilic cells, and we've got a lot of fibrous bands here. So this is where histology starts to break down a little bit in terms of distinguishing these two, and where you may need to use immunochemistry and more particularly the fusion gene analysis. So here we have clearly malignant cells, and these actually look more malignant or more dysplastic than the fibrolamellar carcinoma cells. They're more macronucleoli, there's more variation, and you're seeing kind of a steatotic change here. So although there's a lot of similarities between this lesion and the fibrolamellar carcinoma, there are some subtle differences here. And so those can be very helpful to think about as you compare this lesion with the fibrolamellar carcinoma that we've just talked about. Okay, so I'm going to stop here presenting any new material, and we'll take questions and deal with these. Here's another question from Dr. Lin and her group. Which markers are helpful to distinguish between hepatocellular adenoma and hepatocellular carcinoma on biopsy? Well, we'll talk more about that going forward, but one of the markers that's quite useful is glypican-3, which is usually positive in dysplastic nodules and in carcinomas, and usually would be negative in adenomas. So if you are doing that, that will be helpful. And your question, especially well-differentiated hepatocellular carcinoma. So the other marker that can be quite useful is CD34. So adenomas should not have endothelial cells. They should still be sort of confined to Kupffer cells. And so in general, adenomas will have minimal or no endothelialization, whereas dysplastic nodules and hepatocellular carcinoma does make VEGF or vascular endothelial growth factors and will have CD34 positive cells. And we have used that quite a bit, especially in the well-differentiated adenocarcinoma cases to differentiate those from adenomas. What happened to my... Where's my Zoom picture? I can't see you. Okay, there you are. So any other questions about this sort of early introduction to hepatic pathology and tumors? You've asked some good questions, and I will have to work hard to bring some answers back for you next month, next time we meet. I noticed we've had some other of our colleagues from Phnom Penh join. Welcome to you. Glad you could be with us. I will post and send out this video recording from today's discussion, and hopefully that will be helpful if you would like to renew or review. I will also post a link that is available and open to you to review and look at the digital slides that I've used today, so that you can look at those under your own computer and spend as much time comparing what we've talked about as you would like. Question here from Dr. Seng. Reticulin stain. Very good question. I think reticulin is a very helpful stain in the liver because it does help you define architecture. And usually there would be some difference between hepatocellular carcinoma and adenoma. The adenoma will have a better defined and more normal appearing reticulin stain than hepatocellular carcinoma, where it may be a little bit more haphazard or incomplete, or even just around single cells at times. So that, again, is another useful stain for you. Good question. Any other thoughts or questions? I know you have a full day of work ahead of you, so I will stick around, but you don't need to wait for me. I'm going to stop the recording and we will look forward to meeting again in a few weeks. We'll try to do it again on the fourth Friday of April. Oh, a question about iron stain. Well, we routinely evaluate liver biopsies with iron, with PAS diastase, and with trichrome on any medical liver biopsy. On tumor biopsies, we usually would not use an iron stain unless we thought that there was a background of hemochromatosis or iron storage disease that was contributing to the disease. But for every medical liver biopsy, patients with elevated enzymes and so forth, we routinely do iron stains, because sometimes patients with cryptogenic cirrhosis will show up and they think they've had viral hepatitis, but they actually have hemochromatosis. And we've seen that on a number of occasions. All right, well, I wish every one of you a very good day, a very good weekend, and thank you for joining me.
Yeah, thank you so much, Professor.
Thank you, Professor.
Thank you very much, Professor. So